who has lived experience in recovery, because I am a peer support specialist. And whenever I have had somebody identify with me, I'm more willing to engage in treatment. I am more willing to engage with other providers because I have that support. I don't feel that stigma associated with mental health and behavioral health substance use conditions, right? Whenever we feel accepted, it is huge. And I understand that most providers still, you guys have us in your best interest, but there's still that differential of authority, right? So you're seen as somebody who tells us what we need to do and how we need to do it. Whereas peer support, you know what, I'm going to walk this journey with you and we're going to figure it out together, because I don't necessarily know what's best for you, because I know recovery can happen through many pathways and many means, but I'm here to be that support that you need, because I know what it's like to feel like you don't have any support. All right, so this is another reason why considering integration and leveraging peer support. So, for hospitals to consider, I have a peer support in the emergency department. We can be leveraged across the care continuum through behavioral health practices, through behavioral health units, through traditional medical care and clinics, across the board, people who are there for surgery, infusions. So disease management and prevention, 8,760. So 8,766 hours, that is the number of hours that are in a year. There are typically 6 hours a year in a doctor's office or with other health professionals. That leaves people to 8,760 hours on your own. On our own to self-manage, on our own to self-direct, on our own to make healthier life choices. And if we have somebody that can support us through all of that remaining 8,760 hours, we tend to heal. We tend to feel better. We tend to not need to go back and utilize emergency settings. And it works better across the board. Sorry about that. I went a little too fast there. So if we have someone immediately available to begin supportive services at the time of care, rather than outside referrals and demands of making another appointment, it has proved profoundly beneficial. If I have everything available in one spot, I have a peer supporter there whenever I need to go to the emergency room, not just for myself, but for a family member, parents. Whenever we have to take our kids to the emergency room, we can get very, very emotionally intense as well. And if there's a peer supporter there that can talk to me and help me through my emotional instability so that I can be more effective for my children, that's also another benefit, right? That's going to keep me sane in a time where I could be very ineffective and very unproductive as a parent. And I also would be more willing to return to that medical facility for future care needs. So here are some fiscal considerations. And I really liked this model here of the triangle, so the pyramid. So down at the bottom, we have the continual empowering support, stronger sense of hope and community, increased program engagement, improved confidence, motivation for change. And these are all characteristics that result from peer support. And that leads to achieving sustained recovery, increased program engagement, improved overall health and wellness, decreased uncollected dollars, lower lifetime healthcare costs, and it is essentially fiscally responsible for any healthcare facility to integrate peer support into their programs. So I have included the next 2 slides. They are part of your handouts, but it really kind of demonstrates program effectiveness and fiscal considerations as well. So the University of Arkansas for Medical Sciences in Little Rock, Arkansas implemented peer support in one medical facility in the emergency and medication assistant treatment program for a 1-year pilot. And this is just, these are numbers from one peer support, one individual providing peer support services. So the total of peers approached, you can see there was 524, peers agreed to engage, 501, peers requested assistance for substance use disorder, 212, peers linked directly to treatment, 125, peers that were referred to other treatment, 112, and peers who received take-home naloxone, 191. And the reason that I chose this particular program to highlight is because Arkansas is very similar to Montana in terms of rural communities, with some larger, more populated communities, just dispersed across the state. And that's very similar to Montana's population disbursement as well. And here, this piece here that I really wanted to highlight on is the percentage that won't repeat. So 115 peers are expected to not repeat coming back to the hospital services. That's 22% of the individuals that were supported by that one peer specialist. And that equals the total savings from the peer of the $355,984.64. So minus the cost of the peer specialist, which was approximately $29,000 in this particular pilot program, the hospital saved $326,984.64. Guys, that's a return on investment of 1,128%. And of the naloxone that was distributed on the previous page, there were 3 lives that were reported to be saved directly to the hospital. And then there were also 3 lives that were not reported to the hospital because of direct naloxone use. But later on, it was discovered that they were, because they had access to that naloxone to combat that overdose. All right, so I hope you guys can see through this presentation that peer support can definitely be an integral and collaborative part of the team. And that's why it's included as part of the grant, and the effectiveness is just, it's incredible, guys. I'm a person that is healed because of support from other individuals. My life is transformed, and that's why I'm here before you today. One thing that I do want to touch on is I am aware that there have been, and we've even experienced this in the state of Montana, and one of the things that we are addressing actually is the recovery being possible through many pathways. There have been resistance from peers in other states and even here that, medication assistant treatment is not in recovery, and that is something that we are addressing in our trainings, and it's actually transforming because there's no differentiation between somebody who needs medication assistance to support them through substance use and somebody who needs medication assistance to support them through any manner of life experiences and diagnoses. So with that, I would like to open it up to any questions that you guys may have, any discussion, and we can move forward. Thank you.
Amanda, this is Cindy Sturgar. Can you hear me?
I can.
That was a lovely presentation. Thank you so much. I'm wondering just to remind us, what is the difference between peer support and support groups such as AA and NA? Can you talk a little bit about that for folks?
Sure thing. So AA and NA are 12-step groups. They are typically sobriety groups, and you do not have to have any kind of medication, you don't have to have any kind of specific diagnosis to be a part of those groups. You don't have to have experience with mental health as well as co-occurring disorders. And the main thing is you're not licensed and certified. So individuals who are sponsors with AA and NA groups do not have to abide by a code of ethics. They are not mandatory reporters, and they also do not have to follow the scope of practice that peer support follows. So those are the primary differences.
Thank you. Could you comment as to what their place is in the whole, from the peer support perspective? Like, do you support people joining those? How do you talk about those?
So how do we talk about people who are in 12-step groups? Is that what you're asking me?
Or supporting your folks that you work with to either, if they're in it, if they're not in it? I mean, what's your take
Okay.
on that?
Right. So for me, individuals who are participating in 12-step groups of any kind, I support them in that decision. If they have a sponsor, then that's great, because in reality, I'm not the first crisis contact for any person. I can't fulfill that role because I do have other responsibilities as well, right? But through the many pathways approach, typically a lot of 12-step programs do not support medication-assisted treatment of any kind. I have witnessed this in my own experience through those programs. And so people come back to us after they have gone to those groups, and if they are having to consider medication-assisted treatment or utilizing it, feeling rejected. And that's where peer support can step in. We can help them find alternative community supports, alternative groups, or even consider creating something that is more beneficial to them and helps them feel accepted rather than like they are not part of something bigger than themselves, because that's also another profound piece to recovery. So does that answer that question?
Yeah, thanks so much, Amanda.
Yeah.
Amanda, I have a question. This is Dr. Dan Knotts, and I'm some time ago, and this is a couple of years ago when I was when peer support was just getting going, and there was quite a struggle in dealing with the concepts of low threshold care and harm reduction. And so if you could bring me up to date, I guess, as far as what training is occurring in regards to low threshold care and harm reduction.
So harm reduction is a primary philosophy of peer support training at this point. Whenever we're supporting other people, we must consider if anybody is being harmed in any way. That's one of the reasons why we also abide by the same professional code of ethics that all other behavioral health providers abide by at this time. We are very highly regulated and monitored by the State Board of Behavioral Health. And one thing that has to be maintained, we have to have clinical supervision. It's ongoing, it's maintained. 1 hour, at least 1 hour of for every 20 hours that we provide direct supportive services to other individuals. And through that clinical supervision, we have to verify how we are doing in our own recovery and healing journey, as well as, we discuss the self-care that we use. And one of the things that's actually beneficial is, if we use self-care in our own lives, if we use 12-step groups or any other kind of support groups, the people that we're supporting see us in those roles. And so that also is another level of credibility for us with those that we support, because they see us as, they're actually doing what they're telling us to do. So we teach others what we most need to learn for ourselves often. So that is definitely something that is transforming and evolving. I did just take on the role as peer training coordinator with Montana's Peer Network. And that is one of my considerations as well, is making sure that the peers that are entering the workforce are stable enough in their own journey to ensure that they can be effective in the support that they provide. Does that make sense? Does that answer your question?
Yes.
Okay.
Amanda, this is Tamara, and I'm wondering if you could talk a little bit about if sites are interested in peers and exploring how that would fit into their programs and system. What would they do? How would they do that?
So one of the things that we can do through Montana's Peer Network is provide consultation for any organization or provider that is seeking or considering implementing and integrating peer support throughout their programs and services offered. So you would simply just reach out to me. Tamara, is my contact information available for everyone? Or do I need to just give it?
You know, would you put that in the chat, Amanda? And then I'll make sure to have that on record. And I'm gonna, we're gonna gather everything in the chat box together and get it out for folks.
Absolutely. So I'm putting my email and my phone number in the chat box. And you can reach out directly to me. You can also reach out to Jim Haney at Montana's Peer Network. He's our executive director. And we can consult with you, help you identify your needs and how you can best sustain programs moving forward as you consider peer support. And we're happy to support anybody in implementing that service.
That's great, Amanda. And then I was going to ask Bobby if you could speak to kind of the difference between peer support, care coordination, case management, how things are different in terms of both services that can be provided and then billing.
Hey, Bobby, I don't know if this is you or better for Amanda, but along those same lines, a question that I often get is what's the difference between a peer support person and a community health worker? I don't know if that's also your wheelhouse or Amanda's, but that's along the same lines. Sorry, thanks.
Sure. So Amanda, do you want to answer the question about peer support and community health workers?
Sure. So peer supporters are non-clinical. First of all, community health workers go through a longer training program, at least for the training that's available in Montana, and it is primarily medically focused. So for instance, if diabetes, a community health worker for diabetes would go out into the communities, they would be available to support and be a part of that collaborative team, but peers can work with that individual. They can receive referrals from that individual. You know, if that provider, that care coordinator is going out into the communities and they're seeing needs specific to mental health support, crisis support, and substance use. So that's basically the differentiation there. We don't get into the clinical side of things as much as community healthcare workers can.
So I would just add to the difference between peer support and community health workers additionally is the funding. So right now Medicaid does see the certified behavioral health peer support specialists as Medicaid reimbursable when they work within a mental health center or a state-approved substance use treatment program, and they're seeing individuals who have a diagnosis. Community health workers right now are not reimbursable by Medicaid and could be potentially a funding source or be funded through our grant funds. So I think that there maybe some work to look at Medicaid reimbursement in the future under different healthcare settings for community health workers. But I would just add that right now there isn't a mechanism from insurance standpoint for community health workers, but certainly the need is there to look at that. So in terms, Tamara, of your question with care coordination and case management and peer support, that's a little bit out of my wheelhouse in terms of the Medicaid piece. So I would probably need to have get some more information from our Medicaid colleagues and really identify kind of what is covered, what is not. But I can tell you that, again, peer support is a covered service as long as it's, meeting all the criteria of Medicaid. Under our grants, what we've been doing with these pilot projects is really to be able to provide somebody who can help coordinate the care with the treatment team and the community providers and the community resources. So that can be done by a peer support specialist. It can be done by a care coordinator and funded under this grant. So we have a little bit more flexibility, excuse me, with our grant funds, but the goal is really to help support that individual with their treatment team, their treatment plan, and getting the resources that they need in the community. So again, I don't want to, I'm not educated enough in the differences within the Medicaid system, and I don't want to misspeak to those nuances. But certainly, if anybody's interested, I'd be happy to get some clarification. I do know that the department is working to really define what is care coordination, what is case management and targeted case management, and of course peer support is already very clearly defined, that Amanda has already covered. So I don't, Tamara, does that help answer your question? I feel like I'm kind of pretty
No, it
vague.
does. Yeah,
I
it
can
does.
add
And
something if you would like.
that'd be great.
Okay, so peer support, we can cover as long as we can fit it in within the dimensions of home health, community, and purpose. We do with, we do not do for. There's not that differential. Case managers, at least in my past experience, case managers have provided guidance and direction and told me what I needed to do. They've made appointments for me. They have literally helped manage my care, whereas peer support supports others through self-directed and empowered, self-identification of their needs to best support them and advocates for them based on their voice and choice. So sometimes case managers don't necessarily do that, right? Because you've got somebody who doesn't want to take their medication or wants to switch providers, and maybe that's not the best way to do it. But with peer support, we take that opportunity to have additional conversation and identify the reasoning behind those expressions, those needs that they're stating, and identify if that is the best choice or if there's alternatives to changes or stopping medication that could be detrimental to a person, rather than overseeing them and directing their program of care.
Great, thanks, Amanda. We've got a couple of questions in the chat box, and then we're going to move on to Sherry to keep us on schedule. So Greg was inquiring if peers are available 24/7, and typically not, but definitely evening hours. And peer schedules can be flexible, can be a little bit different. It's not just 8 to 5, because what we know is folks really need support in those late evening hours. And then Lisa, you asked a great question, your hand's up. So I'm going to just go ahead and let you go ahead and ask your question, or do you want me to address what's in the chat box?
My question is just the question in the chat box. If you could direct us to where the documentation is to that you need 1 hour of supervision for every 20 hours of peer support. I was looking for that, and it looked like the language in the law is a little more vague now, and so I just wondered where that was at. Yeah, so this is the legislated language, and then there's rule, which the board sets, and I will make a note to find that for you. Right now it is 2 hours, it's 1 hour per 20, and that supervision can be in varying forms, hallway chats, one-on-one, group, etc. So that is one thing that's on my list, is to get some very specific clarification on the requirements there.
So Tamara, I actually have that available. I can email it over to you.
Oh, that'd be great.
Or add it to the chat box.
Perfect. Thank you so much.